So this is the handout I wanted to go over with you very quickly. These drugs, all of the drugs that I have on this handout, I strongly encourage you guys, if you don't know any other drugs, make sure you know the drugs that are listed on this list. When it comes to pharmacology, it's very important. The type of questions you're going to be asked the most, okay? It's either going to be the adverse reaction of the drug. Now, there's a difference between a side effect and adverse reaction. We use it interchangeably, but they are not the same thing. Side effects are things that can possibly happen, and you're going to warn the patient because we don't want them to stop taking the drug. So you let them know ahead of the time, ahead of time, all of the possibilities, those are side effects. Adverse effects on the other end are things that can possibly happen that we do not want to happen under any circumstances, to the point that you tell them, if this happens, you need to let us know right away, because you expect something to change. You expect the dosage to change, you expect the drug to change, you expect for the healthcare provider to augment that drug in some way. So an adverse effect is worse than a side effect. Okay, when it comes to drugs, you need to know the adverse effects. You need to know the nursing interventions for that drug. You need to know what can happen if that drug works a little bit too well. And Marilyn, let me know if I'm going too fast. I'll slow down because I get excited and I'll speed up my speech. And you need to know the indication of the drug. Now, with this next generation NCLEX, they're asking about the indication. That's easy, guys. They didn't ask much about the indication before, because the indication is, why are we giving this drug? That's easy. Why is the drug given? That is an easy question. Why would you miss out on that? So those are the four most common questions that you're going to get when it comes to pharmacology. You need to know, again, the adverse reaction of the drug, the nursing intervention for that drug, what happens when that drug works a little bit too well, because we're giving something to the patient, we may overcorrect. And of course, the indication, why we're giving that drug in the first place. Now, where I see a lot of students go wrong is that you get distracted. You will get a question that will tell you the patient's diagnosis, or tell you the disorder that the patient has, and then they'll mention the drug that you're either about to give or you just gave, and they'll ask you what your priority action is going to be, or what your nursing intervention is going to be. And I cannot tell you how many times I've seen students choose an answer that's based on the diagnosis and not the drug. Listen to me. I'm telling you this right now. If you get a question and it mentions the patient's diagnosis or disorder, and it mentions a drug that you're either about to give or that you just gave, your answer is going to revolve around the drug, not the nursing diagnosis. So for example, you have a patient that's a diabetic, and you're about to give insulin. What's going to be your concern after you administer a drug? It's not going to be hyperglycemia. If you choose hyperglycemia, you're focusing on the diagnosis. Your answer would not be hyperglycemia, it would be hypoglycemia. Why? Because we know that insulin is going to lower the patient's blood glucose, right? Focus on the drug. The minute you see a drug mentioned, guess what? That diagnosis, that disorder went out the window. That's not what we're focusing on. We're focusing on what is going to cause a physiological change in that patient's body, and that's a drug. Okay? So again, make sure you know those four things that I mentioned about the drugs. Let's take a look at this handout. For each of the classifications or meds, know these important points. One, the classifications and I can't speak, generic names. Now, it's much easier to learn your drugs by the drug class. You're not going to know every single drug, but there are a lot of tips. A lot of times you can either look at the beginning or the ending of the drug to kind of figure out what class it belongs to. And so you should learn from the class. Okay, this class, so for example, beta blockers. Beta blockers, they end in LOL. What do I need to know about beta blockers? I need to be, they're, anti-hypertensive medications. I obviously need to be concerned about that medication working too well. Hypotension. What are your nursing interventions going to be? Well, you're going to make sure that you dangle them before they get up. You're going to teach them not to try to get up by themselves, to press the call button, things like that. Number two, what is the med for? What does it say? What the med is for and which system it affects. That is a biggie. This is why patho is so important, because guys, you are not going to know everything under the sun. But if you have a good understanding of patho, usually you can really eliminate some answer choices to increase your chance of getting the correct answer, right? So same example, we're talking about, a beta blocker. We know that it's going to affect the cardiovascular system. So at the least, when you're looking at your answer choices, you're going to look for something that has to do with circulation or the cardiovascular system. And then number three, it says the nursing considerations before, during, and after you give the drug. Why? Because again, it is the drug that's going to cause that physiological change in the patient's body. Now, here's another tip, guys. Whenever you're being asked about a priority in regards to a drug, you got to think of Maslow's hierarchy of needs. Remember Maslow's hierarchy of needs? You guys learned about that way in first semester in fundamentals of nursing. Well, let me bring it back to the front of your mind. Physiological integrity. What is most important to us, right? What's most important to us is what's most damaging to the patient, what can kill our patient. That's what we're going to be most concerned about. So what falls under physiological integrity? I'm so glad you asked. I'll tell you right now. Abnormal vital signs, right? Heart rate, respirations, blood pressure. What else? Abnormal fluid electrolytes, especially sodium and potassium. What else? Anything that could cause a seizure, anything that can cause an MI. Dehydration. And sometimes, very often, these test questions are going to come out and just say dehydration. They may give you some signs and symptoms, right? Such as, dry mucous membranes, increased H&H. Dry skin, increased temp. Why does that fall under physiological integrity? Well, if you're dehydrated, you don't have enough fluid and electrolytes. I just told you fluid and electrolytes will cause damage to a patient's body, can kill a patient. What kills you faster? Not having enough fluids or not having enough food, not having enough fluids. You can only go days without fluids. You can go weeks without food. So needless to say, any drug that can cause a change in your fluid and electrolyte imbalance, that can cause dehydration, that's going to affect your physiological integrity. That's going to be a priority, right? So seizures, MI, fluid and electrolytes, dehydration, abnormal labs, specifically sodium and potassium, vital signs, anything abnormal perfusion, anything that will decrease perfusion, anything that will decrease the tissues getting the oxygen and vitamins and minerals and nutrients that it needs, that's being carried in the blood, okay? Any of those are going to be a priority. I'm telling you right now. Now let's look at this list. Drugs to know, pharmacology. Number one, calcium channel blockers. Calcium channel blockers, I think I had this twice on the list. There's something else I wanted to say to you about it. Let me see where I can find it. I don't see where I had it. But the two others, I should say, are the verapamil, and if you guys have been following me for any amount of time, you know my pronunciation is horrible, but you see it in front of you, you know what I mean. Diltiazem. All the other ones basically end in -pine. Right? So when it comes to calcium channel blockers, you should be thinking of those drugs that end in -pine, except for those two. Something you got to keep in mind, because a lot of test questions when it comes to the calcium channel blockers, it's going to have to do with your prioritization. What do we care about the most? We're going to care about hypotension. We're going to care about overcorrecting the problem. So the patient was hypertensive. We now gave this calcium channel blocker. All of a sudden, now they're hypotensive. What kills you faster, hypertension or hypotension? Ding, 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 hypotension. Those organs shut down, boom, patient's on the ground. At least when you're hypertensive, your body has these different mechanisms to try to compensate, right? Your blood pressure is up, you're not feeling well, you have a headache, you have blurred vision, you start feeling things are wrong to try to get help. But hypotensive, you're on the ground. There's not much compensation that happens when the blood pressure is low. So that's important to know about the calcium channel blockers. Another drug often asked about is aspirin. You need to know it falls under the salicylate and antiplatelet. When it comes to aspirin, you are going to be concerned about bleeding. You're going to be checking if the patient brushes their teeth. You're going to tell them to report any pink tinge saliva, or, you know, in the urine, or if in the feces, any signs and symptoms of blood. Anaphylaxis, epinephrine. Let's talk about epinephrine real quick. Most important things you guys need to know about epinephrine. It treats shock, but it also, you see, I have anaphylaxis here. It also treats bronchospasms. But you got to remember what epinephrine does. So we may be given this drug to treat the shock or to treat the bronchospasm, but we might overcorrect the problem. So you better be checking the blood pressure. You better be checking the heart rate, because this drug can also cause what? Arrhythmias. Arrhythmias are deadly. That's going to be a priority. Number 4, anti-anginals. Usually have the word nitrate or NITRO. These drugs cause vasodilation. Safety is an issue. We don't want our patient to fall and injure themselves. Number 5, anti-anxiety drugs usually end in like the LAM, PAM, like clonazePAM. Safety is another issue. And something else, these drugs can never be, what's the word I'm looking for when you stop a drug? Not discharge. What's the word I'm looking for? It starts with a D. Discontinued. It should never be discontinued abruptly. And guys, that goes for all psych meds, not only anti-anxiety. When it comes to psych meds, they can never be discontinued abruptly. And this is a famous test question. You mess around and you DC a psych med abruptly, whatever we were giving that drug for, number 1, it can come back even worse. And number 2, you can cause seizures. So never DC abruptly. Number 6, antibiotics. Most of them, like your cephalosporins, penicillins, fluoroquinolones, aminoglycosides, you got to know all of them. When it comes to antibiotics, you see those drug classes? NCLEX asks about all of them. You have to know those drug classes. You have to know those nursing interventions. When it comes to cephalosporins and penicillins, you need to understand the association when it comes to allergies. If a patient is allergic to cephalosporin, they're not going to get a penicillin, or vice versa. Why? Because chemically speaking, the properties are very close. Very important to know. Anti-cholesterol meds, number 7, such as the drugs that end in statin. Very important. When it comes to those drugs that end in statin, you need to know that they're teratogenic. If you're pregnant, you cannot take that drug. It will mess with the fetus. And something else you got to know when it comes to those statins is you're going to be concerned about rhabdomyolysis. That's a biggie, right? So if the patient's on the statin and then they call the healthcare provider, or they call the office, or they call the nurse, and they're like, I'm not sure, but I'm getting, a pain in my left calf. What are you going to tell that patient? You're going to tell them to come in immediately. Why? Because you're going to suspect rhabdo. Okay. Number 7, anticoagulants, warfarin, heparin. Those drugs, make sure you know it. Remember, the heparin starts with an H, and so you remember the test for it is a PTT, because those 2 T's kind of make it look like an H. So the PTT goes with heparin, and the PTINR goes with warfarin. Make sure you know that. Number 9, antidepressants. You guys need to know these drug classes. You need to know the drug-drug interactions and the food-drug interactions, especially when it comes to MAOIs. But let's start with the SSRIs. You need to know that the SSRIs are your first class of drugs when it comes to the antidepressants. That is the first class of drug you expect to be ordered for the patient. Why? Because it's the most effective with the least amount of adverse effects, right? So the patient should be placed on an SSRI. And what happens is when it comes to these psych meds, especially these antidepressant meds, they'll only work for a certain amount of time. So if the patient's been on it for years, this med that was working so wonderfully just isn't working anymore, right? So then they'll be moved to something like a TCA, and then they'll be on that for a while, and that doesn't work anymore. And last, they'll be on an MAOI. What do we need to know about the MAOIs? Those are the very last class of antidepressant drugs we expect to be given to the patient. We give MAOIs when nothing else works. Why? Because there are so many drug-drug interactions and drug-food interactions. Professor D, do I have to know what they are? Yes, you do. I'm so sorry. I'm so sorry. Yes, you do. All right. But I'll tell you now, you better be concerned about hypertensive crisis when it comes to the MAOIs. You better know the foods to avoid. Make sure you know those nursing interventions for all three of them, your SSRIs, your TCA, and your MAOIs. What's next? Number 10, anti-dysrhythmia. Hold on, let me see how I'm doing with time. Oh, I'm doing good with time. Good. Number 10, anti-dysrhythmia, such as amiodarone. You need to know that drug. You need to know that this is the number one drug that we're going to give for, it's our number one drug class for like the patient that's in like VFib or pulses VTAC. Okay, make sure you know those strips. Number 11, anti-hypertensive agents, beta blockers. I talked to you about that. Oh, something I did mention about beta blockers. You got to be careful because you have beta blockers that are cardioselective and those that are non-cardioselective, right? You have your 1 and your 2. And the way you can remember it, you have 1 heart and 2 lungs, right? So if it's 1, it works on only the heart. But if it's 2, it works on the heart and the lungs. Well, guess what? If it's 2, you're not going to give to a patient that already has a respiratory condition, right? Because it can cause bronchoconstriction. So you're not going to give it to a patient that has asthma or cystic fibrosis or bronchitis or emphysema or any other respiratory condition where we're going to be concerned about bronchospasms. Very important. Number 12, I talked to you about that. We did the calcium channel blockers. Number 13, anti-neoplastics. You don't see anti-neoplastic too much. You don't see too many of them. But when you do see anti-neoplastics, 99% of the time, let me tell you how it's going to be presented. The patient, they're going to tell you that the patient has some sort of type of cancer. So that's going to be your first clue that it's an anti-neoplastic agent if you didn't recognize the drug, right? But I'll tell you what your answer is going to be 99% of the time. When it comes to anti-neoplastics, the test writers usually want to see, do you understand that number 1, that drug cannot be delegated to an LPN or LVN, only an RN. And when I say RN, a seasoned RN, a specifically trained RN can administer anti-neoplastics because they are so damaging to the patient if that drug infiltrates, right? So the nurse has to know the drug very well, and they have to be able to monitor the patient very closely. Okay, so that's the most important thing you guys really have to know about the anti-neoplastics. You cannot delegate to anybody else, and you're going to be watching those blood cells very closely, right? Because you expect with those anti-neoplastics, you expect your WBCs to drop, your platelets to drop. So one of your biggest concerns, if not your biggest concern actually, is going to be infection and bleeding. We're concerned about agranulocytosis when it comes to those type of drugs. Next. Number 14, antiplatelet. I talked to you guys about aspirin, bleeding. 15, bronchodilators. Make sure you guys know the difference between your SABAs and your LABAs. You got to know what drugs fall under your SABAs. You got to know what drugs fall under your LABAs. You have to know that only the SABAs are going to be given for emergency situations if the patient can't breathe. You mess around and you give that patient a LABA, they're going to be 6 feet under the ground before that bad boy starts to work, right? You're going to give them a SABA. Make sure you know your rescue medications. Number 16, cardiac glycosides, digoxin. We love digoxin. Cardiac glycosides, great drug for heart failure, right? It increases the contractility of the heart. Wonderful. Unfortunately, it slows down the heart rate. So you better know before you give that medication, you're going to take that apical pulse for a full minute. Number 17, diuretics, you got to know all of them. Don't shoot the messenger. You got to know all of them. You got to know your thiazide diuretics. You got to know your potassium sparing diuretics, you got to know your potassium wasting diuretics. And along with that, you have to know what type of foods you're going to encourage the patient to eat with the potassium wasting versus the potassium sparing. Guess what? NCLEX is not giving you bananas anymore. They know everybody knows about bananas. What are they going to give you? They're going to give you watermelon. They're going to give you potatoes. They're going to give you apricots, dried fruits. Okay. Insulin, number 18, you absolutely need to know the difference between your rapid, short, intermediate, and long-acting insulins. You have to know those drugs, and you have to know when you're going to check the patient's blood sugar, when you're going to assess them, and when you're going to feed them. So let me say this to you. If the test question asks you, when is the most critical time to assess your patient after giving insulin? What they're really asking you is what the peak time of that insulin is. The peak time of the insulin, where the peak highest, right? When the insulin is working the best, that's when the blood sugar is the lowest. Why do we care about that? What kills you faster, hypoglycemia or hyperglycemia? Hypoglycemia every single day of the week. Blood sugar is supposed to be 70 to 110. At least if you have hyperglycemia, your blood sugar's high, your body has so many mechanisms to compensate. Your blood sugar's high, all of a sudden you got polyuria, all of a sudden you got polydipsia, all of a sudden you got polyphagia, right? But your blood sugar's low, boom, you're on the ground. Low blood sugar kills you a lot faster. So we're going to be concerned about hypoglycemic reaction. The peak time of the insulin, when the insulin is working the best, that's when the blood sugar is going to be the lowest. That is the most dangerous time. So whenever a test question is talking about insulin and they ask you when's the most critical time to assess your patient, what they're really asking you is what is that peak time of the insulin. If the test question asks you when you plan to feed your patient, what they're really asking you is the onset of that drug. Because we know that onset, that's when that drug starts to work. You better have fed your patient very shortly within that time frame. If the question asks you, when do you expect to give the next dosage, what they're really asking you is the duration of the drug. So guys, it's not enough to know onset, peak, duration. It's not enough to memorize it. You have to be able to apply it. You have to be able to understand that onset is when I'm going to feed my patient. Peak is when I'm going to reassess my patient. And duration is when I expect to give my next dose. So you have to know when it ends, when you're going to give your next dose. Okay, make sure you guys know the difference in those. Number 19, naloxone, especially, oh, you guys aren't even in Florida, but actually, Maryland, you guys are in Kentucky or what state are you in? Perfect. Yeah, definitely. Naloxone, you guys might get about 2 questions two, maybe even 3, when it comes to opioids. And one of them may be about the antidote. Make sure you guys know naloxone. Number 21, narcotics. Many of those opioids, they have the word morph in them. Make sure you understand if patient you're giving opioids, you better, before you even give that drug, you better be checking that patient's respirations, because we understand that it can cause respiratory depression, right? So if that patient's respirations are already 12, do you think it's a good idea to give it? Absolutely not. You're going to withhold it and call the healthcare provider. Number 22, steroids usually end in -one or -lone, such as prednisone or prednisolone. Important things you got to know about steroids. When it comes to steroids, your top 4 concerns every single time is going to be infection, because remember, steroids will mask the signs and symptoms of infection. So you have to monitor your patient a lot more closely. If your patient's on steroids, a very tiny elevation in temperature may be infection. All right. So we're going to be concerned about infection. 2, hyperglycemia. Steroids are very sugary. They can turn your patients into a diabetic. So you're going to be checking your patient's glucose. Number 3, Ulcers, they are very hard on the stomach. That's why you never give steroids on an empty stomach. You give it with food. It can cause the patient to have ulcers. God forbid you start having bleeding ulcers. And then number four, what is the fourth thing you got to know about steroids? Oh, osteoporosis. Steroids make the bones porous. So you have to be very careful because we don't want our patients bumping themselves and having a fracture. Okay, those are top four concerns when it comes to steroids. Number 23 on the list, stool softeners. You got to recognize doxycycline sodium as a stool softener. And usually, if you get this at the test question, it'll be something like the patient is on this medication. What other teaching would you provide? So you have to recognize that number one, this is a stool softener. Number two, the patient's constipated. So you're going to encourage the patient to what? Drink lots of fluids because fluids is going to help loosen up that stool, and you're going to teach them about the importance of ambulation so they can increase peristalsis so they won't be as constipated. And the third thing is you're going to teach them to increase fiber because fiber pulls all that crap out of your gut. So when you go have a number two, it all comes out. Last on the list, thyroid level thyroxine, that's Synthroid, guys. You guys have to know this medication. When it comes to the thyroid gland, I want you to think about metabolism, right? So when you're giving a thyroid replacement, it's basically acting as that hormone that will increase your metabolism. What does metabolism do? Increases everything, right? Everything goes up, heart rate up, blood pressure up, peristalsis up, thinking up, everything goes up. So you overcorrect that problem, you might have hypertension. You might have tachycardia. You might have hyperthermia, right? You're always concerned about overcorrecting that problem. Make sure you guys know Synthroid, especially blood pressure and heart rate. We're going to be concerned about hypertension and cardiac dysrhythmias. What else do I have on this list? Anticonvulsants. What did I want to tell you about Oh, I know what I want to tell you. When it comes to anticonvulsants, never discontinue abruptly. And if you do, you're going to mess around and throw that patient into seizures. Anti-Parkinsonian agents. What questions do you guys usually get about anti-Parkinsonian agents? The type of questions that I've seen that often appear when it comes to anti-Parkinsonian agents, it'll be presented that the patient's taking the anti-Parkinsonian agent, but the question will usually be about the nursing interventions, like what are you going to teach this patient? It's usually about safety, about making sure that they're keeping their head up instead of looking at the ground because loss of equilibrium, making sure that they take steps, like pretend like there's a line on the sidewalk or wherever they're walking, and to purposely lift their foot because they tend to have that shoveling gait, and we don't want them to fall over. Usually it has to do with safety when it comes to anti-Parkinsonian drugs. Atropine, anticholinergic agent. What are we concerned about those anticholinergic agents? I'm telling you right now, Marilyn, before I say this, because I'm about to be a little inappropriate, but I want the students to remember. Can I or no? Okay. Anticholinergic agents can't see, can't spit, can't pee, can't shit. That's what you remember. Okay. When it comes to the anticholinergic agents, can't see, blurred vision. Can't see, can't spit, dry mouth, xerostomia, right? So you're going to teach a patient to chew sugarless gum. Why sugarless? Because we don't want to turn them into a diabetic. So can't see, can't spit, can't pee, urinary retention, and can't constipation. Those are the biggest concern when it comes to anticholinergic agents. Okay, don't forget that. And last, digoxin, I already explained that to you. Cardiac glycoside, we love it. It's great for CHF, but you have to check the heart rate for a full minute before you give that med. Oh my gosh, and I did this in 29 minutes. I stayed under my 30-minute mark. I have 1 minute to answer questions. Any questions? Thank you so much. No questions. Okay, guys, I'm so sorry. I had to do this so quickly, but my schedule is so packed. If it was anyone else, I probably wouldn't even be able to do it. But for Miss Crabtree, anything for Miss Crabtree. Miss Crabtree, thank you so much for having me. And I look forward to doing this again. I'm hoping I'll have more time next time. But guys, thank you for having me. And don't forget, if you have any issues with pharmacology or you're having problems, doing the nursing math, I have lots of videos on my YouTube channel. You can check it out and you can practice the math with me. And guess what? That math that I do on those videos, it doesn't get harder than that. The math that you get in the nursing program is much harder than the one that you get on NCLEX. If you can follow along with me in those videos with, the drop factors and the type of math that I do, if you can do that, you're going to be good when it comes to dosage calculation on NCLEX. Okay, guys, have a wonderful day. Again, thank you for having me. Study, study, study. Bye-bye.